I just asked Mo to share with you, two of you who weren't there, because I said that all these clinical lectures are interrelated. So their understanding depends upon each other. And we talked about what is the term I use? I'm becoming old as well. Repurposing of drug. So one drug that we find that works in one clinical part, you know, it may not work on the other one. So it's some of the side effects. For example, we want in transplantation for the donor organ to stay. We want immune system not to react. In hypersensitivity, we want it to stop reacting, overreacting. So they're kind of opposite ends. Okay. In cancer, we want the immune system to recognize the cancer as foreign. Right. In transplantation, it's the other way around. We don't want your body to recognize a donor as foreign, because if it recognizes foreign, it's going to react. Right. So it's like the game we play. So today is a very basic disease which is called immunodeficiency. So whatever, remember the game plan all the way, I keep on repeating myself: antigen presenting cell, presenting to T cell and B cell, T cell effector response, B cell effector response, clinical feature, so on and so forth. They are there if everything is intact. We assume that everything is intact, but supposedly they are not. So there is a deficiency to begin with. It's just like you bought a cell phone or you bought a hardware, and hardware is not functional. Hardware is not functional. So there's an issue. Okay? Nothing's going to work because the capability. So that's what we have in immunodeficiency. And since it is more of an anatomical developmental thing, remember I said for some reason the autoimmune diseases are shown in later part of our life, when those cells who recognize yourself as self did come to appear like 30, 40 years ago. We have no answer for that. They come to appear more in women as compared to men. We have no answer. But the immunodeficiency, most of the time, it occurs at birth. The babies are born with defect, most of the time. So it's a neonatal disorder. Okay? Now, the two arms of immune system, one is the immune system which is cellular, and the other one is humoral, which is an antibody. But let's say the cells are deficient. Now we are going to do that. If you remember, there are two kind of cells that we have. The main part of immune cells, right, which are T cells and B cells. So everything we've been doing so far assumes that they are normal. But in this case, they are not normal. When I said that, keep that in mind, immunodeficiency sometimes resembles cancer. And I'll tell you how. Same old slide that I've been saying. So what happens is, if you look at the development of T cell and B cell, bone marrow cells, and T cell, you will see that they go through a phase. So there is a phase, whereas there is a, let's say over here is a stem cell, right? And stem cell develops into lymphoid type cells, right? And lymphoid cells are two, which are B and T cells. So in this case, if you look at the state of development, this is like state of development, which has like from 0, 1, 2, 3, or whatever, 1, 2, 3, and then it is like final development. So the B cell comes like, for example, a pre-B cell, right? And then so and so. Did you miss something over here, or you did not? Okay, now I got it. I know what the issue is now. Now keep in mind, so this is a developmental series where cell goes through a lot of procedures, and then finally a B cell is made. And then B cell, as we know, makes antibodies. And then antibodies go and do the function. This is one aspect for that. The other one is the T cell. It also goes through a series of this developmental phase, and then makes either a CD4 T cell or CD8 T cell, and they kind of interact with each other. T cell talks to the B cell, and then the function is done. This is a normal understanding. Okay? Now this is a slide where most of the questions usually come from immunodeficiency. Now, the very first disease, and you'll see that clinically, the very first disease that you will see is over here at number 1. Okay? And number 1 over here. So the cells from the stem cell, right, they have a difficulty over here to begin with at this level. I would say like 0 level or 1 level. 0 is the beginning, 1 level. So nothing is going to come afterwards because you had a deficiency right from the beginning, right? If you have that in the babies, we call it, over here it's called SCID, S-C-I-D, severe combined immunodeficiency syndrome. So this means arrest at a very basic level. Okay. Now, if you go further, the other thing that might occur is when the T cell develops from 1 to a pre-T cell, there will be an obstruction over here at this level. Right? If that happens in the T cell, there is a disease we call DiGeorge syndrome. DiGeorge syndrome. What have you written over here? What's that?
Like, it was on there.
Show it to me.
Q11.2 deletion syndrome.
Oh, the gene deletion, forget that. Yeah. We don't want to go in that. That's fine. So you can see from here, this one is called DiGeorge syndrome. And we have babies for that, number 2. Number 3 over here, at this level, you can see from here, where the cells would not transform into CD4 and CD8 cell. If it happens over here, right? So we will have a SCID, the same thing, with a deficiency of two types of T cells. So we give a different name where the problem acts at a different level. Okay? And this can happen over here as well, and this can happen over here as well, for both B and T cells. This is for the B cells, and this is for the T cells. And number 4, where is your number 4 over here?
Right next to the pre-B cells.
This one over here, immature B cell. Where's the other one? Show me. Can you show me the actual? Show me. Bring me the book. A arrest happens over at this level, right? At this level, where the B cells don't mature, right? So when the B cells don't mature, one of the biggest things that you will see that there would not be any antibodies. So in this case, no antibodies. So if you were to look at the baby which is born, will have no antibody. This means A means absent, gamma globulinemia. Gamma globulin is an antibody, which is IgG, right? And this is also called Bruton's disease. So if you look at the babies, neonatal, those of you who rotate in neonatology, if you see a baby born with no antibodies, it's called A, gamma globulinemia. Anemia means blood, gamma globulin means antibody, A means absent. Okay? So you can see from here it's called Bruton's disease as well. Okay? Then you go for 5, if something happens at this level, you can see 5 over here. So that's why I told you steps over here in the type, which is called common variable immunodeficiency syndrome. And it comes in various forms because what happens is that there may be a deficiency of IgM, IgG, IgA, so on and so forth. depending upon which particular antibody is deficient, we will have a problem with the antibodies. So various forms of antibodies will be deficient. And this is at birth, because this is happening at birth. That cannot happen. Now the question will you ask that will the baby survive or not? That's a clinical issue. Okay? And then most of the time we see, especially for IgA. So this one IgA, we see this 6. So 6 is the one where you have selective IgA deficiency. So what happens is that these babies on the mucous membrane, and there is no IgA, and IgA is required for mucosal immunity, right? And number 7 over here, where is the 7 on this one? Over here. Is that 7?
Mm-hmm.
Okay. And the 7 over here is called Bear lymphocyte syndrome, which is very important, and we're going to discuss that in over here, I believe. Yeah. Does it say that? Yeah. Right. So there is that issue in this normal reaction for anti-tumor T cell, that there is no Bear lymphocyte syndrome. There is no connection. So it's just like you go and open the log, but there's no log. You have a key, but there's no. So this one is called Bear lymphocyte syndrome, and this is occurring at this level. 7. Okay. Number 8 over here in this where we have C. So IgM is the IgM issue. If you remember, IgM is the antibody that's required for infection. And in this case, what is happening is that we call hyper IgM syndrome. There are too many antibodies being produced which are IgM. Right? So when there is too many antibodies being produced, it can also become a cancer as well. The cancer is also the same thing. The cells out of control. Okay? And then again, if there is a problem with the T cell signaling, as you can see from here, so we call it T cell signaling defect generally. And we already talked about the signaling, very complicated signaling, right? So you can see from here all the way from 0 to the end, whether it's a B cell or it's a T cell, there are different levels of problems that we normally see. Okay. Now this one, the T cell signaling defect over here is shown here. Because what we found out that some of the, I just told you that for some good reason, we don't know why the XX gene has more propensity of autoimmune diseases. So that's maybe like sex linked. So it could be XXS or XY. Sometimes these diseases are more in male children, some are more in female children. This means genetic link. So in this case, what we found out that especially this particular one could be X-linked, right? So if it's an X-linked, this means it's going to happen in both, isn't it? Male and female, right? In this one, if it's Y-linked, it always happens in male. Anita, which one is male, XS or XY? Oh my goodness.
That's why. You say which one is a male?
Male?
Oh no, that's why.
Okay. So you can imagine from this signaling pathway that if for some genetic region, you have a receptor, right? And this receptor has to bind, like it is like a IL-2 receptor, it has to bind with IL-2, right? And if there is something missing, if something is missing, then there is no signaling pathway. We talked about that, simple. So even one portion of proteins which is missing, because normally in order for this to function, you have to have both chains, alpha chain and gamma chain, right? In this case, if one of them is missing, right, so this cannot bind, and there is no signaling pathway that we normally see, and there is no transcription as we discussed earlier as well. If you remember, we talked about this transcription, all those things. So it is happening at the membrane level. Example is IL-2, where there is a chain which is missing, which is gamma chain. So all these things are genetically controlled. It must have been happening for ages, but with this development of genetics, which just found out today or recently. Okay? All right. T-cell infection, this is normal. And if there is no MHC molecule, of course, there is no antigen presentation. Antigen has to be presented to MHC, so T cell would not see that, right? Or if there is a receptor but it's mutated, right, then again it would not lead to signaling pathway. Does anybody recall what was the fast ligand I talked about? And I said there are some drugs available on the fast ligand. Does anybody remember what is fast ligand? When I said that, you know, if you want to garbage something or throw it, you just tag it. It's a death warrant for the cell. If the cell is tagged with the fast, right, and the cell is going to die. So you can see that many a time there could be a missing MSC class gene, or there could be a receptor over here is mutated. This mutated receptor will mean that, you know, I still have a key, but these serrations are messed up. Not going to work, right? So that exactly is a mutation for the signaling pathway where you can see mutated FAS. Okay, and that happens in quite a few diseases, especially hyper IgM syndrome and the Behr lymphocyte syndrome. As the word says, that Behr means without the receptor. Okay. Then problems with immunodeficiency. There may be a problem with the T cell, the problem with the B cell, there will be a problem with the receptors, the genes, right? Or in this case, what happens is defect in cell adhesion, right? So this is a normal cell membrane, right? And if there is a, let's say, infection, then what happens is the neutrophils come, they bind to a receptor, which is E-selectin, and then they are squeezed into where the infections are, and they are going to chew up the microorganism and kill them. That's pretty much the normal case in terms of neutrophil, you know, process. So these processes in this case, you can see from here is that migration of these neutrophils from the blood to the tissue. This is what it is. So these are like typical neutrophils. Now in this case, what is happening is that we have leukocyte adhesion defects. So these are leukocyte adhesion defects. So leukocyte adhesion defects where leukocytes are the white blood cells. Okay? Now if you pay attention to this guy, these guys over here, you will see that let's say if this is like a receptor ligand and the receptor on, but if this is missing, then they will not react. So they will not react, so this neutrophil will not be pulled towards this membrane. Okay? That's number one. The second thing is that maybe if this receptor has two chains, two integrin chain, is missing one chain. If it's missing one chain, again, this will not be squeezed in. Okay? The third thing is that it has all the patent receptors, right? And it is a corresponding receptor, but whenever they talk to each other, this should get activation. In this case, there is no activation. So leukocyte adhesion deficiency syndrome 1, 2, 3. So three type of deficiencies that we see in leukocytes, especially neutrophils. Because you wonder, why do we need to have that? Well, we have to have that because if it's a vascular endothelium, these neutrophils have to go and fight the infection in the tissues. And they have to squeeze. This is like called adhesion, and then they got diabetes, goes into tissue and go to the resources. So these are three important immunodeficiencies that we normally see. Okay? Now, two more. Let's say if a neutrophil has gone into it, right? And it is going to phagocytose, right? But the after phagocytosis, they are lysosomes, they should fuse with phagosomes. But in this case, they do not. Because you remember, if there is a neutrophil and it has taken a microorganism in, so it has to release lysosome, which enzyme to kill this. So there is a issue with, if it's an issue with the phagocytosis, they're unable to phagocytose, then it's called a Shadiac syndrome. That's a disease. One of the commonest signs that new babies will present when they have immunodeficiency is that they will have infections. Okay. The other important thing is that they are able to phagocytose, you can see over here, but they would not be able to release oxygen radicals, because oxygen radicals are required to kill microorganisms. And this disease is called CGD, chronic granulomatous disease. So these are some of the names. I think even if you remember names, there's more than enough of the diseases that we normally see. Okay? So they are, you can see from here, impairment in the mechanism required for phagocytosis, defective intracellular killing. So these are microorganisms. This dark one, they would not be killed intracellularly because of these problems that we normally see. So the top one over here are the problem with the leukocyte adhesion, LAD1, LAD2, LAD3, and these are some of the mechanisms where we have phagocytosis but defective intracellular killing. On the spin side, if you remember, this is a complement pathway, and complement pathway has three branches. One is called alternative pathway, lectin pathway, and classical pathway. This is a complement system. If you remember, the antibodies has the complement attached to them. So what normally happens is that these complements, they bind to these microorganisms, right, and make them like palatable. So you can see the early phase, so they attach to these and kind of present them for phagocytosis. It's like sugarcoat them. Okay? But all these pathways, which may have a different pathway, like some of them use mannose for binding, some of those are going to use microbial services, and some of them are going to use immune complexes. So you can see these are the three pathways. And the thing is that they all converge into all to C5a. C5 and then to C5a and B, right? And they form membrane attack complex. So if you remember, we talked about that in antibody-mediated reaction of cell death when I said all these assembled to like a bullet and poke a hole into the cell microorganism, which is called MAC, membrane attack complex. Membrane attack complex. So this is a deficiency. If there is a deficiency of complement, it could be an alternative pathway, it could be mannose binding pathway, it could be the classical pathway, and all these are different converting enzymes. So you may have a deficiency of either an enzyme or the substrate. So you can see from here, all these steps, A converts to B, B converts to C. A little bit complicated, but we see that, especially complement deficiency syndrome. Typically, we see infection with encapsulated microorganism. We see that in rheumatoid arthritis, especially systemic lupus erythematosus, and we also see in Neisseria infection. So if you have complement problem, you will have infection with Neisseria, right? So these are the three diseases: Neisseria, rheumatoid, and then infections where you have deficiency in complement, which is complement is also part of what is required. Any question thus far? And I think just listening to me once may not be enough. You just have to kind of read it, see it, you know, and then go from there. So let's kind of specific disorders. You can see it's called specific disorder. So it could be a T or B group, right? And you can see from here, the problem will be maybe there are mutated gamma chain of cytokine receptors, as you saw over there, right? There will be mutation of the signaling pathway that we saw on the lower part, on signaling pathway. So these types of things you can see as one set of problems in immunodeficiency. Okay. Then, especially for B positive, and then there are some other deficiencies that we normally see where there is a deficiency of enzymes. You can see deaminase, recombinase, right? And these are the two, and these enzymes are deficient. You can see these enzymes are deficient. Especially this RAG1, because RAG1 is important because it causes cancer. We just said that. Because if there are proteins, and the conversions are that you can have a enzyme, whether it's a adenosine deaminase, ADA, can be recombinase deficiency, and then so on and so forth. But these two, the ADA and PNP, are the common. Then we may have very common, which is called RAG deficiency, right? Partial RAG deficiency, very common that we normally see. And this one, again, you can see from here, happens in Omen syndrome, which is another disease. So get used to these Brutons, you know, the George disease, just kind of roughly idea. And then if you have bare lymphocyte syndrome, when you saw bare lymphocyte syndrome, it could be class 1 or 2 missing. It could be class 1 missing or class 2 missing. Because these are, it's just like the T cell without hands. It's a handicap. So it's not going to present the antigen. It's not going to present an antigen. You will have lot of infections. That's what it is. Okay? And then again, you can have all these signaling pathway. This you remember under the cell membrane. This is a signaling pathway, very complicated. Right? And there are tons of enzymes, right? And we have many diseases. You know, we have listed them over here. It can be multi-system disorders because nothing is going to work, and then you know the effector response would never take place because there's signaling pathway. So you can see all the way from the production of B and T cells, from antigen presentation, from the cytokine release, and from the receptor. You know, it could be any deficiency at anywhere. The question remains, how do we fix it? Right? It's difficult. And the question also remains that the same thing may happen in cancers as well. One of the immunodeficiency that happens, especially for due to infections, you know, immunodeficiency, which this is like primary immunodeficiency, and which is a secondary immunodeficiency. Secondary means due to something, and the most important thing is AIDS, acquired immunodeficiency syndrome, and that's because of HIV. So there's another thing that HIV, which is a virus infection, has an ability to mess up, and how it does it, that HIV actually acts on this cell over here, CD4, and chews it up. So this means all those other functions will be lost. And most of the time the AIDS patient, they present as immunodeficiency. They are not unable to fight off infection, and they also have cancer as well. So, they come with the sarcoma, one of the types of the cancer, which is a muscle cancer. So you can see this complexity in terms of immunodeficiency, right? And what they're trying to do is that they're trying to look for the gene which causes it and replace the gene. Genetic manipulation in terms of, insert the gene. And as I said the other day, that also look at what is the problem that they can fix. Many a times the survivability of these patients, because they're born with the disease, is very low. They hardly go above a certain limit, but you can look it up, in the books as well, that many a times is more of an academic interest, and we are trying to, just like you must have heard about this, what is it called, bubble baby, or there was a boy who had an immunodeficiency, and he was kept in that, there was a movie made of him, on him, right? And probably he died like later, but he did die. So they kind of make sure that the biggest challenge for immunodeficiency is infection. So he was kept in a very special kind of a container so that no infection can go in. I don't recall the name, but Bubble Boy or something like that.
Yeah.
So that's interesting. Some of the science fiction movies are interesting. You'll get an idea. They'll talk about all these things, and you kind of remember more in terms of long-term retention of this information. Okay, any questions? Malik? So on Wednesday and Thursday, we're gonna do the cancer. For cancer, I think what I would do